My name is Dr. Kai Matthes. I'm Director of Developmental Endoscopy at Bethesda Deaconess Medical Center in Boston, Massachusetts. I have the pleasure of discussing our recently published article in the journal Gastrointestinal Endoscopy with the title Efficacy, a full-thickness GI perforation closure with a novel over-the-scope clip application device, an animal study. The motivation to do the study was that the OTAC clip from the company Ovesco recently obtained FDA approval in the United States for the closure of various GI perforations. There have been a series of case reports and case series demonstrating the safety of this device in humans. However, the strength and maximum closure capacity of a single OTAC clip has been still unknown. We wanted to take a look at the maximum closure capacity and pressure threshold of a single OTAC clip in a standardized experimental fashion. We used a validated ex vivo simulation model, the EZR simulator from the company Endosim, for the creation of full thickness standardized defects measuring 5 to 25 mm in ex vivo porcine stomachs and 10 to 35 mm in colon specimens. We used the OTAC clip to be deployed 5 times for each full thickness defect. We also tested the burst pressures of each lesion underwater. For the closure, we used the twin grasper from the company Ovesco, a device that allows a selective opening of 2 sides of a grasper on the left and the right side to adapt the sides of the perforation and bring them together in the center to apply the clip. For the closure, we used the 12 mm T-type OTC clip in the stomach and the 14 mm diameter T-type OTC clip in the colon. Our study showed that full thickness defects measuring 5 to 20 mm in the stomach and 10 to 30 mm in the colon can be successfully closed with a single OTC clip, resulting in reliable burst pressure thresholds of around 50 mm mercury. However, if the tissue defect is larger than 20 mm in the stomach or 30 mm in the colon, the burst pressures appear to decline. Therefore, perforations larger than 20 mm in the stomach and 30 mm in the colon may require more than one OTC to achieve adequate closure. We also found that a pure endoscopic inspection of the closure site does not always guarantee adequate closure. The study adds to the existing knowledge that the clinician should inspect the perforation size before attempting closure with the OTAC. Based on our findings, perforations of larger than 20 mm in the stomach or 30 mm in the colon may require more than one OTC clip or supplemental endoclips to assure adequate closure. The next step is to conduct a prospective clinical study to assess the safety of the OTC in a large multi-center study. I appreciate the opportunity to discuss our research, and I thank you very much for listening.